The following podcast is part of a certified educational activity titled Everything You Need to Know About Biomarker Testing and Treatment of Genomically Altered NSCLC. Access the entire activity and complete the post-test at peerview.com/EYW860. Downloadable slides and practice aids are also available.
Hello, and welcome to Tracking All the Targets in Genomically Altered Non-Small Cell Lung Cancer. Everything you need to know about biomarker testing and treatment. My name is Stephen Liu. I am a medical oncologist from Georgetown University. Joining me today are three expert faculty and colleagues, Dr. Ross Kamich from the University of Colorado, Dr. Alex Drillin from Memorial Sloan Kettering, and Dr. Zosha Petrovska from Massachusetts General Hospital. I think you'll agree that these are three of the pioneers and leading voices of targeted therapy in lung cancer. Looking forward to a very useful and lively discussion tonight. Please note that we'll be using first names during this seminar. We also have contributions from Ivy Elkins, a patient advocate with lung cancer and co-founder of the EGFR Resistors Advocacy Group, and Rashida Persinger, a thoracic nurse practitioner from Johns Hopkins University. And with that, we'll get into our content. Our focus today is on driver-positive non-small cell lung cancer. The detection of actionable genetic biomarkers has really become standard of care for therapy selection and clinical management in patients with advanced non-small cell lung cancer. I think over the years, we've become familiar with EGFR and ALK, but there are many more relevant agents listed on the right with FDA-approved drugs, and more to come. Many of these are relatively rare with incidences of less than 5%, but they are important to detect when present. Unfortunately, as a group, our testing rates are suboptimal. If we look at the relatively low bar of EGFR, ALK, ROS1, BRAF, and PDL1, only about half of patients in a recent real-world data set from ASCO 2021 are getting all 5 of those markers tested. Our rates for EGFR testing are right around 75%. That means a full quarter of patients are not getting a relatively simple test with an accessible and effective drug available. Flatiron data shown on the right show that there are also notable disparities in testing as well, with Black patients less likely to get tested early, and less likely to get full NGS testing. Zosha, were you surprised by these testing rates presented at ASCO?
No, I think maybe more disappointed than surprised. I think we all wish that we were, as a community, and like to think we're doing better. But if I think about my practice and sometimes the patients that I see in consultation, I think it's probably jives with what I see in the clinic. And I think it's important to say this is a very high level overview, just looking at EGFR mutations, not specifically looking at the types of testing or which mutations are identified. And again, I mean, this list does not include any of the recent targets that were shown on the prior slide, which this field has been moving incredibly quickly. So I bet if we looked at the rates of testing for some of those newer targets, it'd be even lower. So again, surprised, no. I think it just highlights how much more work we have to do in this area.
Alex, any ideas? How can we get these numbers where they should be?
Yeah, I think Zosha brings up good point. Certainly, we need increased access to what we think is possibly the best test, so a comprehensive test. And thinking also about the newer biomarkers that are folded into such a test is important. We need increased coverage as well, both on the national level and on an insurance level. And finally, if you build it, they will come is something they say in relation to clinical trials. So also increasing the geographic catchment areas of these trials of newer targeted therapies. And some trials also may pay for travel and lodging that bring people to centers that have these new targeted therapies. And I think all of that rolled together might hopefully increase rates of testing.
What we also saw from ASCO 21 were that EGFR and ALK alterations did not differ in incidence between white and Black patients, but Black patients were being tested less aggressively, and I would argue less appropriately. Dr. Rhea Boyd at one of the oral sessions explained at ASCO, health disparity arises when a racial or ethnic group is made more vulnerable to disease, not because they are more vulnerable. Ross, do you have any thoughts on how we can address these disparities in practice and what impact they're having?
I mean, I think there are many reasons why the accrual rate in clinical trials, particularly for minorities in the US, are low. And I mean, it's a real tragedy, really. I mean, in general, it's low in lung cancer patients, only about 4% nationally, but that's only about 1% if you're African American. I think Alex touched on the point that, geographic spread, placing these clinical trials in centers, with a high density of African Americans, I think is incredibly important. Certainly the molecular testing, if that's a discrepancy, that's not exactly helping matters. And then one of the things that I think is also very important is I think it's important that doctors and healthcare staff look like the patients that they're treating. And, we have as a field tended to be, white men. And, I think it's encouraging to me that we are seeing more minorities going into clinical research, more women going into clinical research. And I think hopefully in the future, things will improve.
Excellent points. So let's go deeper with that first principle, proper testing for biomarkers. I think it's useful to start with a case. This is a patient that came to our clinic, a 54-year-old female non-smoker who came to see us for a second opinion. She had noticed a non-productive cough, had been tested for COVID and was negative, was prescribed an inhaler, antihistamines, but no improvement. With her persistent symptoms, finally someone did an x-ray that showed a left lung nodule. That led to a CT scan. In addition to the lung nodule, showed multiple liver metastases. The liver was biopsied and showed a TTF1 positive adenocarcinoma. PD-L1 expression was 50%. There were no driver alterations on standard reflex testing. Patient had minimal symptoms and was offered immunotherapy from her primary oncologist. She came to see us for a second opinion. Ross, if this case was presented to you just like this, what else do you need to guide your treatment?
Well, this is the cases that we see every week, and the devil's really in the details. So when you say, driver mutation negative, the first thing I'm going to ask is, well, what did they test for and how did they test it? Because your negative and my negative may not be the same thing. And in a never smoker, that's really important.
Increasingly, I think medical oncologists need to be molecular pathologists, and we really need to look at these details. And true enough, when we did push a little further, we see PD-L1 was 50% using the DACO22C3 clone. EGFR, BRAF, and KRAS were wild type by PCR. ALK and ROS1 were wild type by FISH. And so I turn it back to you.
Well, so so the plus points, they've sent off some of the testing, as we've already said. There's 10 molecularly specific subtypes of lung cancer. They haven't checked all of those boxes, but even the ones that they have done, you could critique them. When you've got PCR-based testing, that can often mean a mutation-specific primer, and you got to ask them, well, what exactly were they looking for? So you worry there are some blind spots even in their EGFR and KRAS testing. For the FISH testing, I mean, that's good for ALK and ROS1, but we also know there can be false positives and false negatives. It's quite a user-dependent technique, and a whole bunch of things that they haven't looked for. So the first thing I'm going to do is, if the patient is able and willing to, is to get more advanced testing.
Now, Zosha, this seems like a fairly limited panel. Do you still see this done in practice?
Sometimes I would say less and less now. I think there's really been a big movement to move towards broad NGS-based panels that cover a lot of targets and have broad coverage of these targets. But it does still come up. And I think there are some practices that really have stuck with their single gene testing. And it's really an inefficient way to test cancers now. And I think we really have to move away from it as a field.
Yeah, we're certainly more advanced now. These are FDA-approved tests, but I don't think that they're really state-of-the-art. We all have different workflows at our institutions, in-house versus send-out testing, reflex testing versus investigator or oncologist ordered testing, pros and cons to each approach. Alex, can you walk us through the differences between these two general strategies?
Yeah, very happy to. And I think one way of moving away from single gene testing, is really to have a good internal workflow. And that's what you're looking at on this slide, where in the pathology lab, when they receive slides, you have reflex testing. And we know that if you have a comprehensive test with an algorithm all worked out, that it can increase testing rates, decrease the turnaround time. And also they're able to best select which specimens to use, do calcification that has an impact, decalcification on the molecular profiling of some samples. But the other major piece in this, obviously, is input from the treating oncologist. And for that particular situation, obviously, you provide the clinical context, Sometimes there are samples which need to be tested in the resistance setting, and sometimes you may need to look to an additional test beyond the initial test that you've done. We can get to that a little bit later on. But at the end of the day, I think there needs to be very good dialogue between the path lab and the treating physician.
Yeah, communication really is important. These testing results are critical. They're really needed to provide best care. They provide some insights into the biology, patterns of spread, other complications like venothrombotic events. They allow us to provide prognosis, but above all, they help to guide initial therapy, really from the jump. They allow us to select targeted therapy when it's appropriate and allow us to deselect immunotherapy. Ross, what do I mean when I say that?
Well, I'm really glad you actually kind of called out the elephant in the room. So one of the things about deselecting immunotherapy is sometimes the first test you get back is PD-L1. And we know that many of these driver oncogenes can have really high levels of PD-L1, but it doesn't mean the same thing. In a classical lung cancer, high PD-L1 is assumed to represent a surrogate for saying there were immune cells, T cells coming in there, trying to attack it, and then they're kind of rejected by the presence of the PD-L1. But we know, partly from some great work that came out of Zosha's institute a few years ago, that sometimes if you look in ALK and EGFR, there could be high levels of PD-L1, but no T cells at all. So it's kind of a false signal, and it's not really predicting that you're going to respond to immunotherapy. And I think that real worry if somebody sees 100% PD-L1 and they rush for pembrolizumab, that may be the wrong thing. For example, there was a nice study that was called the Immunotarget Registry that just looked when people were giving sort of immune monotherapy, how did these driver oncogenes influence response? And certainly, in the simpler cancers and often in never smokers, the response rates were much less than you would expect. ALK, I think, is one of the standout examples with almost a 0% response rate in most of the reported studies. And you can see that here. Now, for others, there are exceptions. KRAS and BRAF, and to some extent MET, can occur in smokers, and therefore that rule may not apply uniformly to everybody, but it's certainly something to think about.
Now, Alex, you were involved in this registry. Do these results mirror what you're seeing in your practice?
Oh, yes, absolutely. And I think that beyond response rate, we also need to look at the durability of benefit, because if you look at this slide, even though there are subsets where the response rates approximate 20% or north of that, you see that the progression-free survival with these agents is fairly low, and most of them are in the 2 to 3 month range. And this is what we see in the clinic, that if someone comes from the outside, again, PD-L1 was used as the primary sort of diagnostic to select therapy. For many of these cases, we see patients blow through single agent immunotherapy in particular and need a switch in strategy.
Now, as Ross mentioned, sometimes we see very high PD-L1 in the context of an EGFR mutation, like a deletion 19, and it means something different. But there's such a force behind immunotherapy with direct-to-consumer advertising, with patient interest. Zosha, do we have any data about immunotherapy in this setting?
We do have some data. It's a great question. And I think, one of the things that comes up a lot when we talk about this is patients are coming and they're eager to start treatment. They've just been told they have stage 4 lung cancer. And, as soon as we get any information, they're asking, well, what treatment should I get? And I think it's really important to highlight the fact that not only are we trying to pick the therapy that's most likely to be effective, but we also have to think about the safety of both the treatment we're starting with and the safety of subsequent therapies. And so, if we look, there was a small study. I always say this is a small study, but really one of the more useful studies that I think we've seen in a while. I think it's unlikely to be repeated in a larger data set, but is really instructive. This was a study done by Dr. Lisberg and colleagues out in California. And this was a study looking at patients who had known EGFR mutations, newly diagnosed patients who were also PD-L1 positive. And the majority of these patients were actually had PD-L1 greater than 50%. It was planned to be a 25 patient study looking at frontline pembrolizumab in this patient population. So instead of starting a TKI, starting with immunotherapy. And it was actually terminated early because of futility, because this was an ineffective strategy. They only enrolled 11 patients. They saw only one response. And when they centrally tested that one tumor, that patient didn't actually have an EGFR mutation. So essentially there were no responses among the EGFR mutants. So this was an ineffective strategy, but I would argue maybe more importantly than the fact that it was ineffective, which we might have predicted, the use of first-line pembrolizumab had an important impact on how patients did when TKIs, which we know are likely to be the most effective therapy for these EGFR mutant lung cancers, were introduced after immunotherapy. And here we saw that in 7 patients who received TKIs in this study, there were 3, in fact, grade 3 or higher treatment-related adverse events, including 1 case of fatal pneumonitis out of just 7 patients. And I think this is really telling and important for us to recognize that not only is immunotherapy ineffective in these patients, but once we find the EGFR mutation, if we're not waiting for that testing to come back up front, if we try to then pivot and switch to a TKI after starting an immunotherapy regimen, it can be really hard and the toxicities can be increased. We also saw some data out of Alex's institution from Dr. Schoenfeld and colleagues looking retrospectively at patients who had immunotherapy and later went on to EGFR inhibitors. And we saw that when patients were treated with osimertinib after immunotherapy, the rates of severe immune-related adverse events were unexpectedly high with osimertinib. About 15% of patients had severe IRAs with osimertinib after immunotherapy, including the majority of those being pneumonitis. And I think that's really important to know. So when you have patients who've had prior immunotherapy, you have to be really cautious in introducing TKIs. And again, it really highlights the fact that when we first meet patients, we want to have as much information in hand before starting treatment to ensure that we're able to select the treatment that's most likely to be effective and safest for that patient.
And we need to get it right the first time. The sequence matters, and really the stakes are quite high, as you point out. So we need testing. We need testing early to get initial therapy, but the type of testing matters. We can't just say test and check a box. There's tissue versus liquid. There's single gene versus multiplex or NGS. There's DNA versus RNA. Liquid biopsy, it's something that's gaining a lot of popularity. Ross, can you walk us through liquid biopsy as a platform?
So it sounds wonderful, the idea that a cancer can shed its kind of molecular footprint into the blood, and if you have appropriate testing, you can find it in the blood. So it's got tremendous advantages in terms of it's just a blood sample, so it's very convenient. It can often be very quick, but it has some flaws associated with it. The burden of cancer will impact how much you can actually pick up, the location of the cancer. So thoracic only disease, we know, has a certain tendency to shed less into the peripheral bloodstream. And then there's a kind of black box called sheddability. So some cancers presumably have a higher turnover of their cells and they shower more stuff into the blood than usual. I mean, if you look at the different pros and cons, obviously tumor tissue is slower, but it's much more specific, it's much more sensitive, and it's probably a little bit more expensive. If you look in the blood, it's easy, it's quicker, and it's cheaper. So it's not unusual in when the system allows it to actually send both off at the beginning, particularly if the patient is symptomatic and you need a rapid result. But you need to know that a negative result on cfDNA doesn't mean there's no cancer there. And then the other thing to point out is this is purely a DNA-based assay. That's the only stuff that's stable enough that you can actually pick it up in the bloodstream.
Now, you mentioned DNA testing, a critical point. A lot of the tissue platforms we use are often DNA-based, but some are also RNA-based. Some are dual extracting and running for both. Alex, why is RNA testing important?
Yeah, I think if you look at this next slide, you'll see that there are a lot of technical issues that are listed here. But long story short, there are some events that are much more easy to find on the RNA level. And fusions are one of those events. So there are issues related to how you pull down, so to speak, these fusions on DNA. And it's hard to do that if you have rearrangements where there are very large introns like NTRK2 and 3, or repetitive introns like ROS1. And then, of course, there are other more complex genomic events or issues with sample purity that lead into the inability for DNA, even a very good test, to detect every possible event. And what we did at our center is we actually tested the hypothesis. And here on this slide, you're seeing everyone with lung adenocarcinoma that went through a very good comprehensive DNA-based next generation sequencing test. Our internal test is called MSK Impact. We took everyone that was driver negative and asked, have we missed anything? And we did RNA-based sequencing with anchored multiplex PCR. And lo and behold, the top line results are on the right. You see that in about 15% of cases, DNA-based NGS had missed a almost canonical driver for many of these cancers. And as you can guess, a lot of them were fusions given the limitations that were discussed earlier, but there are also complex genomic events like MET exon 14 alterations that were detected. And so our approach now is whenever possible to try to consider doing RNA-based testing. Some people do that sequentially in DNA negative cancers, but some also do double extractions and do that up front.
So we need early testing. The type of testing matters. We need broad panels, but we also need to know exactly what we're looking for, and the details increasingly matter. Saying something is positive is no longer adequate, and so we can't say HER2 positive, we can't say MET positive, because these mean different things. You know, when I say MET positive, Ross, what does that mean to you?
Well, I'm glad you said that. I actually think that, it's almost like saying, I have lung cancer positive patient. And you go, well, no, we need more details these days. So MET positive could mean many different things. So it could mean a MET gene fusion. These are incredibly rare, but are actionable. It could mean, for most people, because there's a licensed drug, a MET exon 14 skip mutation. That's about 4% of lung cancer. There are MET point mutations. That's usually not in lung cancer. They're described in kidney cancer, for example, although they can be mechanisms of acquired resistance. And then there's MET amplification. So that increases the number of copies of the gene. That's a continuous variable. And so your positive and my positive might be different. And so the devil is really in the details. And then finally, even though it's not routinely used yet, is MET protein expression is sometimes called positive. It was initially used as a means to select for people to get MET tyrosine kinase inhibitors, but it might be coming back in because it wasn't successful in that area. It might be coming back in as a marker for some antibody drug conjugates. So yeah, you're absolutely right. MET positive can mean so many different things, it's almost meaningless, and you've got to go down to the details.
And you have to know what you're looking for when you make the order. And so when we order for RET testing, for example, and again, another drawback of single gene testing is you need all these details. When we look at something like RET, Alex, what we're looking for now is maybe different from what people were looking for years ago.
Yeah, exactly. So we first knew about the role of RET in oncogenesis in the context of it as a mutation. And as many of you know, that's in multiple endocrine neoplasias, where you can have germline or somatic mutations in RET that lead to oncogenesis. But in lung cancer, similar to papillary thyroid cancers, the event that drives cancer growth is really a RET fusion or a rearrangement. So it really is important to pay attention to your molecular report. And the last thing I'll call out is sometimes you'll get an equivocal call for a rearrangement or a fusion being present. So nice buzzwords to keep in mind are that you're seeing an in-frame event that includes the kinase domain, because that's what you're looking for as sort of a bona fide real fusion that may drive oncogenesis.
But even saying mutation might not be enough. We need even more detail in some cases. Ross, we recently saw FDA approval of sotorasib for KRAS mutant lung cancer, but not for all KRAS mutations, specifically for the G12C mutation. I guess my first question, are the tests we're doing now for KRAS enough to provide that information for everyone?
Well, it goes back to, exactly what test you're looking for. So yes, if you have a report that comes back and says KRAS mutation positive, that is not adequate anymore. We need to have something that actually tells you the mutation. Some of the PCR tests will not tell you the specific mutation. So for example, we have drugs, as you've already mentioned, for KRAS G12C. That's about just under half of KRAS mutations, but people are developing drugs for G12V, G12D. The orphan in the pack is the Q61H mutation that nobody's made a drug for yet. But unless we test for these things, unless you know your patient has this specific KRAS marker, you won't know what trials to send them for. And increasingly, trials are active. They're not just a science experiment anymore. And so the more you know what's going on with your patient, the better.
I think a brilliant example of that is sotorasib in KRAS G12C. We saw some updates from this at ASCO this year. Ross, can you tell us a little bit about sotorasib?
Yeah, so sotorasib is a G12C inhibitor. It's not a KRAS inhibitor, it's a KRAS G12C inhibitor. It's very specific. The study actually enriched for patients, or pre-selected patients based on the presence of a KRAS G12C mutation. It didn't actually allow untreated patients in there. So there were second line and beyond, and they were treated at the recommended phase 2 dose of sotorasib, which was 960 milligrams. What you could see when you look at the efficacy was something like a 37% response rate. Now that's pretty good. Duration of response, 11 months. Clearly the people who are responding are behaving like a true driver oncogene addicted. I think one of the things that's somewhat surprising though, is that not everybody's responding. And I think what we're at is the beginning of a journey for sotorasib and not the end of the journey. So the question is this to do with the drug or is it to do with the biology? My gut feeling is it's to do with the biology, and that even within KRAS G12C, there is some molecular heterogeneity which is influencing responses. We don't know exactly what that is. We know some of the things it isn't. So we saw some updates at this year's ASCO that P53 didn't matter, that potentially STK11 didn't matter. There's still a hint of a signal for KEAP1 co-mutations. But in general, when you've got these kind of drugs, this wasn't a randomized study, but we are seeing patients staying alive longer. So suddenly KRAS is joining that group of patients who have targeted oncogenes when they have G12C. In terms of adverse events, well, it's a pretty well tolerated drug. It's oral, and you can see there's some diarrhea, some nausea, a few laboratory abnormalities. But in general, for most patients, this is a transformative treatment if you're in the as yet unfully understood subgroup that is sensitive to the G12C inhibitors, even within G12C.
Yeah, that heterogeneity, important, still very impactful drug, will make a difference for a lot of patients, a huge therapeutic window. Zosha, KRAS mutant isn't enough information. We need the specifics, we need the details, but the same's been true about EGFR for a while now, right?
Absolutely. So here is a very simple diagram of the EGFR gene and what we have to think about when we think about EGFR mutations now. And, I think it really highlights the fact that it's important to recognize that, for all of us who work in academics and see patients with these mutations all day, every day, it's easy to keep these, keep these in mind and know how to keep them straight. But it's also, I imagine, really hard, when you're also seeing patients with colon and prostate and breast cancer. And I think it's always, appropriate when you get a report and you're not sure what mutation this is, to reach out to a colleague, a friend, to the company that issued the report and try to get some clarity, because it is so important to recognize these mutations as different. So now within EGFR, even, we have different categories of mutations. We have what were previously called sensitizing mutations, but maybe more appropriately should be called the most common mutations, the exon 19 deletions and L858R point mutations. These still make up the majority of EGFR mutations that we see in lung cancer, and those are very sensitive to drugs like osimertinib, which of course is approved along with several other first and second generation EGFR inhibitors for those mutations. We also have what are commonly called the atypical but still sensitizing mutations, like the G719 mutations and exon 18 and others. And those actually, afatinib is the FDA approved therapy for those, although there is some data with other drugs as well, which we'll cover. And then there's this new category of EGFR exon 20 insertions, which comprise this long list of heterogeneous mutations and are important now to recognize. This is a heterogeneous subgroup of mutations. Hopefully, when you receive reports now, they will actually identify these as EGFR exon 20 insertion mutations, because it can be hard to know which they are. But it's important to recognize these because, one, they're less sensitive, at least to first and second generation EGFR inhibitors from what we know. Historically, these have had a worse prognosis than the more common EGFR mutations, but I think that was largely related to the fact that we didn't have effective targeted therapies for these. And now we are starting to see both clinical trials and a recent approval of therapies specifically targeting EGFR exon 20 insertions. So again, highlighting how important it is not just to say EGFR positive, but to recognize which mutation you're talking about. This slide just really highlights the fact that, exon 20 insertion mutations are quite a heterogeneous group of mutations. There's a number of different ones that fall into this category. And this is some data that really highlights the fact that here again, PCR-based tests that are specifically looking for one mutation or another aren't enough. They actually underreport and under-identify these mutations by about 50% in these different data sets. And next generation sequencing is a more effective way to identify these. So again, a plug for NGS. When we look at some of the drugs that are in development for EGFR exon 20 insertions, the one that is probably most on people's minds is amivantamab, which is a bispecific antibody to EGFR and MET, which we'll cover in the next few slides. But I did also want to highlight that there's a number of other oral targeted therapies that are being developed for EGFR exon 20 insertions. Some of these you can see here listed on the table, including poziotinib, one of the first drugs to be developed for EGFR exon 20 insertions, which had shown some promising early results, although the later follow-up data showed maybe more limited efficacy with significant rates of toxicities, which I think have led to dose reductions and maybe limited the drug's efficacy somewhat. This year at ASCO, we saw some updates with mobocertinib, formerly known as TAK-788, where we saw that the response rate is actually about 28% among 114 patients who had previously progressed on platinum-based chemotherapy. That was the response rate by blinded review. And there, the median duration of response was 17 months, and the overall median PFS was about 7 months. Mobocertinib does have FDA breakthrough therapy designation, and is certainly a drug to keep an eye on. Although again, with mobocertinib, we see high rates of EGFR-related toxicities, including diarrhea and skin toxicities that we have to be mindful of. You can see here there's some data with osimertinib, as well as a number of other compounds that were updated this year at ASCO. There was the compounds from Cullinan, Dizal Therapeutics, as well as Black Diamond Therapeutics. And those are all new and emerging drugs for EGFR exon 20 insertions that I think we'll probably see more about in the coming years. But I think when we talk about EGFR exon 20 insertions, it's hard not to spend a moment focusing on amivantamab, because this is I think actually it's now no longer the latest therapy approved by the FDA for lung cancer, because sotorasib beat it by just a few days. But just recently, we saw the approval of amivantamab, which again is a bispecific antibody targeting EGFR and MET for EGFR exon 20 insertion mutant lung cancers. And here we have the data from the phase 1 Chrysalis study that led to the approval. This was a population of 81 patients with EGFR exon 20 insertion mutant cancers here. And I'll point out that 100% of these patients had had prior platinum-based chemotherapy. So the approval here is second line and beyond. Some patients had had prior TKIs, although not all of them. And what we saw with amivantamab was a response rate of 40% in this population. The median duration of response was 11 months. The median PFS here was 8 months. And I think what was really nice in this data set is, as I mentioned, this type of mutation can be quite heterogeneous, and there can be some structural kind of differences between the different types of mutations depending on where they fall in the exon. But what we saw when we looked at the amivantamab data and broke it down by these different types of mutations was that there was really no clear signal that one mutation benefited more than another. So I think we can say now that when you're thinking about using amivantamab, it's enough to recognize that your patient has an EGFR exon 20 insertion. At least today, you don't have to yet worry about whether it's in the near loop or the far loop or anything else like that, maybe in the future. Just a word on toxicities with amivantamab. I think generally this drug is fairly well tolerated, although things to keep an eye on include dermatologic toxicities. So you can see here in this data set that about 86% of these patients did have rash, although the majority of these were low grade, grade 1 or 2, and only 4% were grade 3 or higher. Some paronychia and stomatitis, relatively lower rates of MET-related toxicities, including hypoalbuminemia and edema. And then the one to keep an eye on with amivantamab are these infusion-related reactions, which occur in about 2/3 of the patients who receive this drug. When we hear about these reactions, they tend to occur almost universally on cycle 1, day 1. They have been mitigated by some of the strategies that have been implemented, including splitting that cycle 1, day 1 dosing into 2 days, so cycle 1, day 1 and day 2, and some additional pre-medications on those first 2 days of treatment. And generally, these have been mild. As you can see here, the rates of high-grade infusion-related reactions have been low, and most of these patients have successfully been able to go on to receive subsequent doses, even after having an IRR on day 1 or day 2. So, something to keep an eye on, but generally has not precluded patients from being able to receive these therapies.
So we have common mutations, we have atypical mutations, we now have exon 20 insertion. Alex, we also have data for exon 18 EGFR mutations, right?
Yeah, no, it just underscores that we should be paying attention to the particular mutation flavor. And if you remember from Zosha's earlier slide, these exon 18 mutations are either in the late 600s or the early 700s. And the most popular of these would be the G719 substitutions. And we've seen that with this particular group, that there is data showing that while we're seeing responses across EGFR TKIs, that perhaps the second generation covalent type TKIs might be a good fit for these. And a few years ago, we saw the broadening of the FDA label for afatinib, a covalent inhibitor that was inclusive of G719X. But at ASCO this year, as you can see on this slide, we're seeing another agent, neratinib, approved in the breast cancer space. And the top line data, you'll note that the objective response rate in TKI pre-treated patients, so patients who had gotten other EGFR TKIs in the past, was 40%, median duration of response of 7.5 months, and a median progression-free survival of 9 months. So very exciting data, really broadening the reach of different TKIs in this space.
These are hugely important points. Longevity is partnering with us in this program to bring in the patient perspective and highlight the importance of having these open conversations with patients about their diagnosis, about biomarker testing, and the subsequent treatment options. We've developed a video tutorial with a patient and a nurse practitioner to illustrate how to have these challenging conversations with your patients. Let's pause here to watch an excerpt from this video, as well as some reflections and recommendations from Ivy Elkins as a lung cancer patient and advocate, and from Rashida Persinger as an experienced thoracic nurse practitioner. Be sure to check out the full-length video tutorial, the Longevity Resource Compendium, and the supplemental practice aids for clinicians afterwards.
Hello, Ms. Elkins. My name is Rashida Persinger, and I am the nurse practitioner who partners with your doctor. It is my understanding you have further questions surrounding biomarker testing and why it is needed before proceeding with treatment. Is this correct?
Yes, I feel overwhelmed with my diagnosis of advanced lung cancer and all of the new terminology I need to understand. Could you explain again why I need biomarker testing? I read something online about testing for mutations. Is that the same as biomarker testing?
Great questions. Biomarkers are measurable characteristics of your cells that can provide information about your lung cancer. Certain biomarkers are drivers, such as mutations that cause cancer to grow and spread. Mutation testing or molecular testing or biomarker testing are all terms that refer to the same thing. In case of targeted therapies, biomarker testing looks at the genetic makeup of the cancer or its DNA. This is different from the DNA we are born with. This DNA makeup can provide information to guide proper treatment options for your lung cancer. As clinicians, I think my takeaway points for other clinicians is to understand the role that we play when patients present with this new diagnosis, with new information being thrown at them, and the expectation to understand everything in one sit down. We have to avail ourselves to be able to break down terminology, be available multiple times to explain these terms so that for when patients walk out from us or when they are talking with their family members or when they are trying to communicate and understand it for themselves, it is in their terms under their way. And so therefore they can have a good knowledge base of why we need to do biomarker testing and why it's important to have all the results and why we would like to wait and hold off for chemotherapy. In my experience, I have found that when we take that time to explain to patients, sometimes multiple times, that anxiety level decreases and they have a better understanding of why it is so important in having these results.
I think one of the most difficult things for patients when they get a diagnosis of advanced lung cancer is understanding all of the new terminology that all of a sudden is being thrown at them. There's just so many new terms that unless you already have a background in something medical, that as a brand new patient, it's hard to understand. Biomarker testing, targeted therapy, etc. And even if it's explained to you, sometimes it takes several explanations to really be able to comprehend everything.
So once we've done our proper testing and we find what we're looking for, which is an actionable driver, what next? How do we select our initial therapy? In general, we're avoiding immunotherapy based on the data that Zosha reviewed with us. Sometimes we have to choose between chemotherapy and targeted therapy. But when we choose targeted therapy, what influences our choice if there are multiple drugs available, which is increasingly the case? When we look at these studies and their different endpoints, we'll be comparing across studies response rates, progression-free survival, overall survival for some of the more mature studies. Is overall survival the ultimate endpoint? Is PFS the be-all, end-all? Should we look at that? Ross, what kind of endpoints should we be looking at when we're looking at these studies?
I mean, it's really amazing to see how the field has changed over the last 10 years. To some extent, we could be accused of shifting the goalposts. The alternative is that we're just really maturing as a field of thoracic oncology. For a long time, if you think about the EGFR inhibitors, even when they were going in EGFR mutant, people were saying, well, they clearly improved the response rate, they improved the PFS, but they didn't improve overall survival. Now we don't really care about that because we recognize these patients live long enough that they can play catch up later. And I think what we're starting to see is this going on with other driver oncogenes. So, should you choose a drug based on the best PFS? The answer is sometimes it depends on what price you're paying for that prolonged progression-free survival. And if the overall survival is much, much longer, are you really going to be able to play catch up later? If they're very short, where PFS is just a very close surrogate of overall survival, maybe you're going to prioritize that. If it's only a fraction of somebody's overall survival, maybe it's not the thing anymore. In terms of overall survival, which sounds like a really hard endpoint, we've got to draw a distinction between an overall survival in the study, which is due to the sequence of therapy, you get the drug now as opposed to later, versus access to the treatment. If you have a study that doesn't allow crossover and it's going on in countries where you don't have access to the drug, that's a totally different thing when you're trying to apply it to a population where they might have access to the drug in later line therapies. So the short answer is everything. And so, overall survival is hard, but I think it's kind of fuzzy and it's pushed down the line and lots of things can happen. PFS is probably what you're going to go on, but there's a lot of devil in the details to try and figure out whether the gain you get in PFS is worth it.
But it's not a simple algorithm. Like you mentioned, we have to look at everything. That includes toxicity. And when we open an article, we look at the trial results for toxicity. A lot of us hone in on those grade 3 and higher toxicities, the severe life-threatening toxicities. But in this setting, we need to look a little deeper. And we also have to think of non-clinical things like cost. Zosha, how do these factor into to your selection of frontline therapy?
I think they're really critical. I think in some ways we have an abundance of riches for a lot of these targets now with many drugs. And I think, looking at safety profiles is really critical. And as you pointed out, it's not just the high level toxicities. When these patients are on treatments, sometimes for years, even the low grade chronic toxicities can be a real problem and have a real impact on patient quality of life. So I think that's a real critical example. And, I'll give you an example in EGFR. Sometimes you'll see low grade, grade 1 or grade 2 diarrhea, which looks like not a lot on paper. But when you're with a patient in clinic who, that patient says, gosh, I have to plan my day around when, where bathrooms might be or things like that, I think it becomes incredibly important. So I would say, in terms of toxicities, I think it's really critical to sit with patients and talk to them about their experience on these therapies, what might be more tolerable toxicities for their lifestyle than others, and really trying to make a decision together as to what the best treatment for that particular patient is. I think cost is also an incredibly important, point. And, there's the cost of the drug on paper, and then there's also the cost to the patient, and that can vary widely depending on the type of insurance or whether patients have insurance, what their copays might be. So I think all of those are important. And frankly, I think cost is one that we probably don't think about enough. And certainly we don't think about enough in the United States, not to mention the rest of the world. So all of these are really critical points that we have to take into account. And it's a good problem to have that we have many drugs to choose from. But I think all of these are factors that we have to use in treatment selection.
If we look at all these factors that we're considering in our head as we're approaching a new target, I think a good example would be RET. Our shifting approach on RET, I think, is a good example. Can you walk us through what's happened with RET as a target over the past few years?
And like you said, this is a very good example of a situation where we have a lot of options, but it's important to make a distinction between the old options and the new options. And this story that you're going to hear is really a story that's a testament to rational drug design. And on this slide, you'll see that in the past, prior to mid-2017, we had these older agents, which were multi-kinase inhibitors, had some modicum of inhibition of RET, but really weren't purposefully designed to inhibit only RET and avoid other things. And examples are cabozantinib and vandetanib. But fast forward again to mid-2017, where you see in these kinome dendrograms on the right, we saw the entry of these selective RET inhibitors, rationally designed TKIs that have a very clean profile, inhibit RET, maybe a few other kinases, but don't really pound other kinases like VEGFR2 or KDR that lead to side effects. And in the next slide, you'll see the gains of this new strategy where we're really designing drugs much better than before. Here you see the registrational data set for selpercatinib, one of these selective RET inhibitors from the Libretto trial. And you'll see the nice waterfall plots between the treatment naive and platinum chemotherapy pre-treated patients with RET fusion positive lung cancers, where going from cabozantinib, vandetanib, where you're seeing response rates in the order of 30%, now you're seeing response rates consistently in the 60 to 80% range associated with durable disease control. So for selpercatinib, the median progression-free survival for platinum pre-treated patients is north of 18 months. Now moving on to the other drug that's also approved in this space, here we have the pralsetinib regulatory data set from the ARROW trial, again, kind of phenocopying what you saw in the prior slide. And here we're looking at platinum pre-treated patients, where you're seeing in the different color-coded bars that didn't seem to matter if they had gotten prior chemotherapy, didn't also seem to matter if they had an older multi-kinase inhibitor or immunotherapy. Patients stood to benefit from really the best-in-class drug. And in this update from ASCO, you're seeing here in patients who are eligible for chemotherapy, the response rate rise to 80%. And beyond the metrics that you're seeing on these slides, we also saw a very substantial improvement in the safety profile, which, as you've heard from Zosha, really matters a lot. And you're going from cabozantinib, where 3 out of 4 patients will require a dose modification, to selpercatinib and pralsetinib, which have much fewer drug-related side effects and are much more amenable to chronic dosing.
Yeah, real success story here. And I think another good example, and maybe one of the more complicated spaces to navigate, is ALK fusion positive lung cancer. Ross, maybe you can walk us through that space.
Yeah, so it's complicated, but at the end of the day, some of these things are just sort of have gone out of fashion. So crizotinib, a first-generation drug, if a patient's on it and tolerating it and doing well, you don't need to change, but you wouldn't start a new ALK-positive patient on crizotinib anymore. Now you have a selection of drugs which are approved in the US, and some drugs, such as ensartinib, are likely to be approved in other countries, such as China. Entrectinib, it's on the list here as a second-generation drug. Honestly, it's not licensed for ALK, and really most of its focus is on ROS1 and NTRK. But if we think about the ones that you're actually going to use, well, it's really down to about 3 drugs now. It's alectinib you could start with, or brigatinib, or lorlatinib. Those are the next-generation drugs which really have standout efficacy in the first-line setting. If we look at the ALEX trial, which was alectinib versus crizotinib, you can see with mature data, one of the suggestions is, that it really has a very long median progression-free survival. Now, you can manipulate that number a little bit depending on whether an investigator is looking at it as opposed to an independent radiology committee. But you're controlling disease in the majority of patients for between 2 and 3 years. One of the things really interesting when you look at the progression-free survival, the blue line here in the top left-hand corner, there's almost 2 populations. There's a population which is progression before the median, and then there's a long tail of non-progressive. The immunotherapy field had sort of, captured the imagination about the tail of the curve, but I think we're going to start to see these data sets presented with 2 years, 5 years, maybe even 10 years follow-up, and we're going to start to look at stuff beyond the median. There's the overall survival data you can see there, which is actually positive. But remember, in ALEX, no crossover was allowed. And I think it's very interesting to look at the J-ALEX study, which was essentially the same design done in Japan, which did allow crossover, has no overall survival advantage. So I think that's a fluke of trial design as opposed to truly telling you that sequence matters. You can see on the top right that we're getting CNS responses. Obviously, CNS activity is included in the overall efficacy data set, but that's still very encouraging to see. If you look at brigatinib in the post-crizotinib setting certainly looked like it was superior to alectinib. It had consistently the longest median progression-free survival, running about 15 to 16 months, whereas alectinib was running about 7 to 9 months. Yet in the first-line setting, it behaved almost exactly identical. Every efficacy endpoint essentially was the same as in the ALEX study. And I think it's a viable option, but it also has activity post-alectinib, which isn't in its license. And certainly that's something that you can use. It also has good activity in the brain, and it's very well tolerated. It's also 1 pill a day. I think the thing that really shook up our thinking was the CROWN study. The CROWN study was this third-generation drug, lorlatinib versus crizotinib. Of course, it was a positive study. We were expecting that. I think from seeing the ALTA-1L, maybe we were expecting to look about the same, but it didn't. Suddenly, it didn't have a hazard ratio of about 0.5. It had a hazard ratio of 0.28. It really looked like a game changer in terms of efficacy. And yet its uptake has been somewhat hesitant. And I think this starts to illustrate what we began talking about is PFS the important thing? If you look at the progression-free survival for patients who may live 10 years with metastatic disease, you're really talking about their time to the first treatment decision. And are you putting that off successfully with lorlatinib? Probably yes. But what price are you paying in terms of the side effects? Lorlatinib is, in some patients, a great drug. In other patients, it can really be a tough drug to give with weight gain, peripheral neuropathy, and neurocognitive effects. And I think that's made people think that maybe, this is something that you could keep into a later line therapy.
We have a few different options there. Lorlatinib is a very controversial agent here. Zosha, can I turn to you for ALK fusion positive non-small cell lung cancer? Do you have a preference in the frontline setting?
No, I think it goes back to what we also started talking about, which is the toxicities and, what toxicity profile may be best for a particular patient. And I think that's an important conversation to have. I agree with Ross. This data from the CROWN study looks incredibly compelling and just remarkable to see. I think the story also highlights the fact that it's really hard when we have a number of different head-to-head trials all comparing against a standard of care, an older standard of care that's probably no longer the right comparison. And what we'd like to see is more head-to-head comparisons of these drugs. But for now, this is the data that we have. So, I am one of the people who worries a bit about the long-term toxicities, particularly of lorlatinib. Some of the neurocognitive side effects I've seen be tough for patients. And when patients are on these drugs for a long time, that can be a real challenge. On the flip side, the second generation ALK inhibitors have, their own unique side effects. And for example, with brigatinib, sometimes we can see those early pulmonary toxicities. With alectinib, you can see myositis and other things. So, I think more commonly, I've reached recently for second generation ALK inhibitors, waiting for more data from the CROWN study, but I think they're all reasonable options. And I think it's worth having a conversation with patients as to, what kind of toxicities they might be more or less willing to tolerate or what their lifestyle is like and how it might impact them.
Yeah, a discussion with patients about the relative merits and really sharing in that decision.
That's
I also
right.
struggle a bit with the neurocognitive side effects. If you're changing someone's personality a bit, which can happen in some extreme cases, it really becomes more of an existential toxicity. And it really is challenging for some patients, especially those who live alone, can sometimes lose their independence. I really struggle with that as well. Alex, what are your thoughts in this frontline space?
I don't think I have much to add on top of what Ross and Zosha already said. I do think that lorlatinib can be hard to push through for some patients, and so my preference would be to start with either alectinib or brigatinib. I will bring up a point, though, about drug design again, going back to that, and I would like to see a highly selective ALK or ROS1 inhibitor enter the clinic, because what we're seeing with lorlatinib, the neurocognitive side effects, the peripheral neuropathy, the weight gain, many of those are probably mediated by the drug tickling track A, B, or C. And so if we can sort of divorce the ALK-related activity of a newer TKI from the other kinases that come with side effects when you inhibit them, then we might end up in a better place.
Well, another thing we've learned over the years is that many of these driver positive cases of non-small cell lung cancer have a strong tropism for the brain. Patients with driver positive lung cancer often have brain metastases at diagnosis, which can be asymptomatic, and so important to include MRIs with and without gadolinium to screen for those, or they will develop them over time. And so an important part of surveillance really is CNS imaging. We've learned to monitor the brain with imaging to focus on CNS efficacy with many of the targeted drugs. And our historic approach has really been radiation when brain metastases are present, but that may be evolving. Zosha, what are your thoughts on radiation in this subset of patients?
I think it really is an evolving question. And, we've talked in the earlier sections about how some of these newer generation agents have improving CNS efficacy. And we've certainly seen that in the case of EGFR mutant cancers. With osimertinib, one of its big advantages being improved CNS efficacy. Very many of our patients, as you know, with EGFR mutant lung cancer have brain mets at diagnosis, sometimes symptomatic ones, and then, also commonly small asymptomatic brain mets that are picked up on MRI. And we often see these patients in multidisciplinary clinic when they're first coming to us, and often we'll see them with a radiation oncologist. And I think it's always important to have a conversation about radiation, but more and more with improving CNS efficacy of these drugs, particularly osimertinib, I would say that we are moving away from upfront radiation for these patients. And when we talk about radiation, I think it's also important to clarify what type of radiation we're talking about. For years, we were using whole brain radiation therapy for these patients. And I think, whole brain radiation therapy can be tough, both during and after treatment, but then also in some patients can have some long-term neurocognitive effects, which can be difficult, particularly as we're looking at survivals of these patients, extend and longer, and patients are now living years. I think it is a really important consideration. And, I think whole brain radiation is rarely the best choice up front for a patient with an EGFR mutant lung cancer, although I will also say that there are some cases where you've really exhausted your options for CNS penetrant therapies, and sometimes it is the right choice. And so I'm always wary of kind of nasing whole brain radiation too much, because then when you get to that patient where you have to use it, it can be a challenge as well. But certainly I think upfront, for patients with small and asymptomatic brain metastases, I think the data here suggests that using osimertinib is a good strategy to use. For patients with symptomatic brain mets, sometimes we'll use a combination approach, use a targeted radiation approach to something that's larger or we're worried about, and then use osimertinib to treat small asymptomatic brain mets. Here you can see some of the data looking at CNS response rates, both with older drugs like afatinib and erlotinib, where we saw some CNS activity, but clearly inferior to the response rates that we're seeing within the central nervous system with osimertinib, where CNS response rates are 50, 70%, even higher in the frontline setting. We also have seen that, leptomeningeal disease, a dreaded and very difficult, type of cancer to treat, has in some cases had nice responses to osimertinib. I think this is particularly true when you have patients who develop leptomeningeal disease who haven't yet been exposed to an EGFR inhibitor or haven't yet been exposed to osimertinib. For those patients, the Bloom trial, which looked at osimertinib at 160 milligrams instead of the standard approved dose of 80 milligrams, showed that there can be responses. I think it's challenging with leptomeningeal disease. CNS response rates may not fully capture the benefit that these patients can get from osimertinib. Sometimes you can see clinical benefit, neurologic improvement, even in the absence of radiographic improvement, just because leptomeningeal disease can be so hard to assess radiographically. But definitely for patients who develop leptomeningeal disease who have not yet been exposed to osimertinib, I think that can be an effective treatment strategy. When we look at the frontline setting, here again, you can see that all of the EGFR inhibitors do have some CNS activity. So it's not that osimertinib is the first drug to penetrate the CNS. But when we look at the FLORA trial, I think these numbers are really striking. When we look at the CNS response rate of osimertinib of 91%, the CNS progression-free survival was not reached yet at this analysis. I think this has been really one of the success stories of osimertinib in the frontline setting, and likely has been one of the reasons it's been such a successful drug. We saw some responses, 68% with gefitinib and erlotinib, but for patients with brain metastases, I think osimertinib really can be a very effective strategy. And again, when you see that patient in the clinic who has small and asymptomatic brain metastases, I think pause before considering kind of the reflex move to radiation, and often starting these patients on osimertinib quickly and watching them closely with a follow-up brain MRI, often in conjunction with radiation oncologists who are there and ready to treat if need be, can be a very effective strategy. And I think many of these patients will have really nice responses in the subsequent MRIs and can avoid radiation at least up front.
Well, it's such a critical subset of patients, and we really need to look closely at that group of patients. And when we look at FLORA, which was that randomized phase 3 study of frontline osimertinib versus first generation TKI, we did see a breakdown in efficacy by CNS metastases present or absent. Ross, your impressions?
Well, so I think The great thing is that starting to recognize the importance of the brain in terms of clinical trial design and clinical trial efficacy endpoints is fantastic. But we also need to know that there's still quite a long way to go. If you look at this, the headline is, look, the hazard ratio in FLORA is the same whether you do or don't have brain metastases. Therefore, you should conclude that osimertinib is somehow kind of nullifying the effect of is not somehow nullifying the effect of brain metastases. But of course, what you don't know here is in the group that have brain metastases, how many of them have had radiotherapy, and of the ones who've had radiotherapy, how many had whole brain radiotherapy versus SRS? They reported the proportion who had radiotherapy. They didn't break it down. And if you sterilize the whole CNS, of course, your outcomes are going to be better. The other thing I would take away from this is even when you look at this, sure, the hazard ratios are the same, but look at the median progression-free survival with osimertinib, our supposed CNS penetrant drug, both with and without brain metastases. There's a 4 months difference in the median progression-free survival. I still think there's some gas in the tank to get better CNS penetrant drugs and to generate more robust data. I mean, if we look at overall survival in FLORA, it's pretty good. Okay, so we're doing something, we're really extending it out. But just to go back to what we talked about in the ALK space, one of the questions you've got to ask here is this sequence that's important, or is this access to drug? If we can guarantee our patients second-line access to osimertinib, maybe we can play catch-up. Maybe some people are going to fall into that valley of death between first and second line. And that's going to vary in your practice and in your country.
Well, CNS efficacy, clearly an important factor to consider when we're thinking of targeted therapy here for EGFR. But Alex, this paradigm applies elsewhere too, right?
Yeah, absolutely. And I think what we're seeing is that in terms of drug design, that the more contemporary agents really have CNS activity baked in. And so if you're looking at the two FDA-approved drugs for TRAC, larotrectinib and entrectinib, both of them have achieved CNS objective response rates north of 60%. We're actually even seeing responses in primary brain tumors. For ROS1, the most recently approved drug in the TKI-naive space, entrectinib, we're seeing good objective response rates in the CNS and a duration of response north of a year. And for RET, we're also seeing selpercatinib and pralsetinib achieve those sort of contemporary outcomes that we're seeing with the EGFR TKIs as well. And going back to what Zosha said about leptomeningeal disease, actually we've seen response to leptomeningeal disease in a RET fusion positive non-small cell lung cancer with one of these selective RET inhibitors. And then finally, also these drugs that are used, the next generation agents that are used in patients who are refractory to prior TKI, we also see good CNS activity for ROS1, for example, repotrectinib. We've seen the CNS outcomes for a subset of patients treated with that drug, and also lorlatinib in the ROS1 space this time. In fact, there was also one patient in that data set with leptomeningeal disease who had a response to therapy. So for CNS, the future is looking bright across different oncogenes.
Well, once we weigh all those factors in, we choose our initial agent. We're going to be monitoring for toxicity, adjusting as needed. We're performing our serial scans, paying attention to the CNS. And as impressive as the responses are, we also know that they're transient. And while some can be more durable than others, we do expect resistance eventually. But if a targeted drug works and then stops working, if we haven't changed our treatment, then it means the cancer must have somehow changed. And sometimes we can pinpoint exactly what that change is. In some cases, like with resistance to first and second generation EGFR TKIs, there's a dominant mechanism of resistance, like T790M. In other cases, like ALK, there's a mix of on-target mutations, bypass tracks, and others. So I guess my first question for this panel, should we be repeating molecular testing and biopsies for everyone with driver-positive lung cancer at the time of first progression on TKI? Now, I want you to take yourself out of your own clinic where you have a lot of trials at your fingertips and really put yourself in a busy community practice. Zosha, why don't I start with you? What's the role for biopsy and molecular testing?
It's a really important question, and I think it's one that comes up a lot. I think to a certain extent it depends on the driver, but as a whole, I think what we hope to show you in this section is that biopsies are important, and that some of these, sometimes we can identify things that can be targetable. I'll give the example of EGFR mutant cancers. when we were looking for T790M after first and second generation EGFR inhibitors, the story was very easy. And these were mutations that were readily detected by liquid biopsies. You could send off a blood test if it was positive. You could put patients on osimertinib. Now with resistance to osimertinib, it's become more complicated, but you can still identify driver alterations, MET amplification being one example. I think histologic transformation is also really important to highlight. And again, we'll go into more detail about these, but histologic transformations are an important point to make because they can be missed on liquid biopsies. Liquid biopsies don't tell us about the histology of the cancer. So if you have a patient who has rapid progression, who's got widespread new METs, who's behaving clinically like the phenotype of their cancer may have changed, I think particularly there, it's important to do a tissue biopsy for molecular testing, but also for simple histologic analysis to see, are you still dealing with a non-small cell lung cancer, or could a transformation have occurred, which of course can have important implications for how you treat that patient.
Ross, do you agree the role of biopsy here?
I do. I mean, I think there was a period of time we used, so Zosha mentioned EGFR, we use ALK as an example. When people were progressing on crizotinib, rebiopsying was more of a kind of, academic exercise because most of the next generation inhibitors had about a 60 to 70% response rate. But now that we're using these better drugs up front, we're getting much more niche mechanisms for resistance, specific mutations that only one drug will work on, or second drivers where you can add in another drug. So if we think personalized medicine is important in the first line setting, it's just as important in the acquired resistance. I think we do need to analyze now.
Alex, same thoughts. And are your patients receptive to the thought of another biopsy?
Oh, yeah, absolutely. And I think if you frame it in the same way that when you do the molecular analysis, when they're newly diagnosed, it helps find them or match them to a particular therapy. In the acquired resistance setting, we're also seeing hints that you're able effectively triage patients to targeted therapy, a particular type, or sometimes even to chemotherapy. And for the latter, beyond histologic transformation, one point I'll bring up is that sometimes you see a mixed bag of resistance where you might see a clear emergent kinase domain mutation, but then you also see hints that maybe another kinase is activated. And so for cases like that, it might not be as straightforward as putting them on another pill. But in my case, I would prefer to consider chemotherapy before circling back to something like a next generation TKI on a new trial.
Resistance is really how our treatment evolves. And if we look at the case of EGFR as an example, we know T790M mediates resistance to the first and second generation TKIs. Osimertinib was developed to overcome that resistance, and the waterfall plot from the AURA study is shown there on the right. So then we move osimertinib to the frontline setting, and we prevent T790M from occurring. And as we've already covered, that leads to better outcomes. But we still see resistance to osimertinib. It just looks a little different now. Zosha, do you want to walk us through that story?
Sure. Osimertinib resistance, I think, is becoming more and more of a challenge in the clinic. We're seeing more and more patients starting to progress on this drug and really having to figure out what to do. And focusing here first on this pie chart, the first thing to say is that our understanding of resistance to first-line osimertinib is still quite limited, actually. There's only a few data sets out there. And I think we still have a lot more work to do to fully understand the different ways that cancers become resistant to osimertinib. But just looking at this pie chart, I think the first thing you can see is there's not that one big piece of it. There's not the T790M here that's going to be, the low-hanging fruit for developing the next line therapy. There's a wide variety of different resistance mechanisms that can be seen, including both on-target resistance mutations within EGFR itself, C797S, and other C797 mutations, and other EGFR mutations. We see some off-target or bypass pathway activation, MET amplification being the most common one of these, but still seen in only about 7 to 15% of these patients. And we'll come back to treatment for that in a moment, but I also highlight there are other bypass pathway activation mechanisms that can be seen, including RET and BRAF and ALK and other fusions. We've also seen MET exon 14 skipping in a small number of these patients. So really a wide variety of different resistance mechanisms that can arise and in some cases can be treated. And then I'll finally highlight that 40 to 50% of these patients won't have anything that we can identify in our current testing algorithms. And for these patients, it's really a challenge of what to do and how to treat them. We don't have a targetable equitable option. When we do look at resistance to first-line osimertinib, I think looking for MET amplification is one of the things that actually I hope to find. And it's seen in about 7 to 15% of patients, as I mentioned. And the reason that I'm hopeful when I find it is that because we know that this can be something actionable. And we've seen data here from the TATAN trial where patients responded to a combination of an EGFR and MET inhibitor. So here osimertinib and savolitinib with a response rate of about 30% in the post-osimertinib setting. We've also seen anecdotal case reports of responses to other MET inhibitors, like combinations of EGFR inhibitors and crizotinib as well. So definitely something that we can consider targeting when we find MET amplification in patients who've progressed on osimertinib. We've also seen rare but recurrent fusions, as I mentioned, in RET and ALK and BRAF and other oncogenes, and sometimes these can be targeted as well. I think one of the challenges with some of these is that they're rare and they're hard to study in large clinical trials. We're really relying in a lot of these cases on case reports to help guide us in what to do. And I think the challenge with case reports is that we publish them when they're positive, but we're not as eager to publish when they're negative. So always important to take with a grain of salt. And there are studies that are, really more fully evaluating the ways to target RET fusions, for example. But we have seen case reports of patients who have acquired fusions in RET after osimertinib, progression on osimertinib, and we can see responses to the selective RET inhibitors that we talked about already in this program, like selpercatinib and pralsetinib in combination with osimertinib for those patients. So if you find one of these, I think it can give you a good option for patients. I think this year at ASCO, we saw a couple of updates on drugs, again, that we've talked about already in one case in this program. And I think what's exciting to see is starting to see drugs that may work for more than just one specific subtype of osimertinib resistance. So first, I wanted to briefly mention the data for amivantamab. Of course, this is the bispecific antibody to EGFR and MET that we talked about for its approval in the EGFR exon 20 insertion positive patient population. But here we're actually talking about the combination of amivantamab together with lazertinib, another third-generation EGFR inhibitor in patients with EGFR mutant non-small cell lung cancers who progressed on osimertinib. And we saw that this was an active combination for patients who had progressed on osimertinib. And in particular, when we look at the type of resistance, we can see that this was particularly active. I'll note small numbers here, but a response rate of 47%, 8 out of 17 patients who progressed on osimertinib and had identified either EGFR or MET-based resistance mechanisms. So here we're talking about either secondary mutations in EGFR or MET amplification or other activation of these two pathways. And when we saw those, we saw that amivantamab and lazertinib was an active combination, and there's ongoing clinical trials of that. We saw that this was perhaps slightly less effective, although still had a response rate of 29% in patients who had who didn't have identified EGFR or MET-based resistance, and in particular for patients who had other pathways activated, it seemed not to be an active combination. So still a lot to learn about how to best select patients for this treatment strategy, but exciting to see. And then finally, I wanted to highlight patritumab deruxtecan, which is HER3-DXd, or an antibody drug conjugate to targeting HER3. And this year at ASCO, we also saw an update on HER3-DXd, patritumab deruxtecan, in patients who had progressed on first-line osimertinib. We saw that these patients had a response rate of 39% and a median progression-free survival of 8 months. And to me, what was most exciting about this data set was here responses seem to occur regardless of resistance mechanisms. So this seems like a promising treatment options for a number of our patients, not just ones with one particular resistance mechanism or another. This seems like an active agent in a number of different populations. So, I think this is really exciting to see. And I look forward to seeing more data with this drug to see where it fits, but exciting to see new treatment approaches, new types of therapies for patients progressing on osimertinib.
But it's not just osimertinib. We see these paradigms apply to all targets and similar studies and results with NTRK as well, right, Alex?
Yeah, and we've already told you previously that the two FDA-approved TRK inhibitors, the first generation ones, larotrectinib and entrectinib, can work very well. However, at some point, patients do develop acquired resistance, and the story is similar. In fact, it's similar across other oncogenes as well. Here on this slide, you're seeing the acquired mutations in NTRK 1, 2, 3 that can occur with larotrectinib or entrectinib. And the good news is that next generation pills that you'll see on the lower right are currently in development that have been designed to abrogate resistance by these mutations. And before we leave this slide, the three major categories of these on-target changes are either substitutions that occur at the gatekeeper, you've heard that for EGFR. At the solvent front, these can be relatively more recalcitrant than some other mutations, and also the XDFG motif. But moving on quickly to one of these next generation TRK inhibitors, here we have selitrectinib or LOXO-195. This is data that was presented at AACR. And here you see that patients who have kinase domain mutations, the response rate was 45%. And interestingly, if you pulled out patients that had bypass resistance, although the N was small, in 3 patients who fit into that category, we did not see responses to this next generation kinase inhibitor, really highlighting what we had talked about early on. And we've also seen responses with another next-gen TRK inhibitor, repotrectinib, in the TRK refractory space. But also good to know that this drug is versatile in that it was also designed to hit these recalcitrant mutations that can occur in the ROS1 fusion positive context. And I'm calling out things like G2032R, where we've seen clinical proof of principle of patients who have these mutations in their cancers and respond to repotrectinib. And I'll also call out that in the RET fusion positive space, there are drugs like TPX-0046 that have been designed against the solvent front, and emerging drugs like HM06. And hopefully we see the utility of sequential TKI therapy in these other oncogene-driven contexts as well.
So the field is moving quickly. We're going to biopsy, if only to be sure there's not histologic transformation. Sometimes we're going to find alterations that may guide us towards a new targeted drug or a clinical trial. But chemotherapy also can still play a role in a driver-positive lung cancer. Ross, your thoughts on chemotherapy in this space? And maybe a question, if we do move to chemotherapy, do we continue the kinase inhibitor?
Yeah, I mean, it's really interesting. So there's a couple of things. So one is chemotherapy, when you've kind of run out of your targeted therapy options, I think is an alternative. Some of the things that we've found out over the years is that the driver oncogene may influence your sensitivity to some specific chemotherapies. All of the gene fusions, ALK, ROS, RET, NTRK, seem to have exaggerated sensitivity to pemetrexed, but that's fortunate because that's also the drug that you would probably include with carboplatin. The real question there, in fact, there's 2 real questions. So the first is there any role for a kind of retro move for using chemotherapy up front to kind of depopulate the cancer? That's certainly being explored in some studies, particularly in EGFR, and people are thinking about describing that in ALK. But the other one is when you get to the point where you're on your TKI and you've run out of targeted therapy options, do you just stop the TKI and go on to chemo or even chemoimmunotherapy? Or obviously, you can't do this with the immunotherapy going. Do you keep the TKI going through the chemoimmunotherapy or through the chemotherapy? There's a study called COMPEL, which is at least trying to explore this in the EGFR setting. There's some soft retrospective data in both ALK and EGFR from our own institution in Zosha's, suggesting there may be some benefit from keeping the TKI going, especially in those with brain metastases, but we're trying to generate prospective data on that.
Zosha, your opinion on the TKI with chemotherapy?
No, I think it's a strategy that we really have to look at prospectively in this space. I think, there was older data from the IMPRESS study with first generation EGFR inhibitors and progression there. And there we saw, I think to many of our surprise, that when patients moved from first generation EGFR inhibitors to chemotherapy, there was no benefit to continuing with that first generation TKI. But I would caution that, I think osimertinib is a different drug than the first generation EGFR inhibitors, in particular with respect to its CNS penetration, as we talked about. And I think the COMPEL trial will really be an important study to answer this question prospectively. And, for now, when I have patients who have progressed, who had prior brain metastases, which are controlled on osimertinib, their systemic disease is progressing, but the disease in their brain remains well controlled on osimertinib, I think there is kind of a thought to continuing. And I have in my clinic continued the osimertinib together with chemotherapy. I think we need prospective data to really tell us what's best here, but it's an important question.
Alex, any concerns about safety with combining these targeted drugs and chemo?
Yeah, and I think Ross alluded to it as well. And this goes back to the earlier discussion about TKIs post-IO. And you can imagine what happens when you give a TKI with immunotherapy. We've seen side effects increase, and this, things have been published such as crizotinib after prior immune checkpoint inhibitor, where we see a transaminitis. And then also last year, we've heard about selpercatinib hypersensitivity, also in the wake of prior immunotherapy. So I think we need to tread lightly when we consider combinations like that.
So when we talk about targeted therapy, we're often thinking of oral tyrosine kinase inhibitors, but there are many other options available now and in development. We want to touch on some of these different classes of drugs like monoclonal antibodies, bispecific antibodies, antibody drug conjugates, some of these also being explored in combination with TKIs. And a target that's emerging that I think encapsulates these is NRG1. Alex, can you talk a little bit about this target?
Yeah, I'd love to. And I think this is a great example because here what we're seeing, maybe for the first time in lung cancer, is what I'd like to call an oncogenic ligand. So these are technically fusions involving neuregulin or NRG1 that lead to this chimeric oncoprotein that sits on the cell surface but displays that ligand for HER3 that then subsequently on activation dimerizes with HER2 and activates oncogenic signaling in the ways we are familiar with. But at the core, it's really hopefully interfering with that interaction of ligand binding with the HER3 receptor. That is the therapeutic strategy. And that brings us to what Stephen said, sort of what's old is new again. And maybe we can capitalize on these large molecules, these newer bispecific antibodies with 2 different epitopes, or even sometimes a mixture of antibodies to abrogate signaling in that context. And so here in the next slide, we're seeing a presentation from ASCO of one of these large molecules, zenocutuzumab, in NRG fusion positive cancers. I'll point out that this was a basket endeavor, where here we're seeing the tumor agnostic data, including pancreatic adenocarcinomas and other tumor types with NRG1 fusions, but also including lung cancers. And you'll see that the top line data, you see an objective response rate of almost 30% in all tumor types, in pancreatic adenocarcinoma 40%, and non-small cell lung cancer 25%. So sort of providing the first proof of concept for interfering with an oncogenic ligand in this particular situation.
I think another good example is HER2. And again, to focus on the details, in lung cancer, we're focused more on mutation, not so much overexpression or amplification. But we've seen some activity with kinase inhibitors and other molecules. Ross, can you walk us through HER2?
Yeah, so HER2 mutations, these are actually exon 20 insertions too. The most common is an insertion which codes for 4 amino acids called YVMA, although there are other ones. And they are kinase inhibitor responsive. This is the data from poziotinib, a 42% response rate, PFS looking fairly modest at 5.6 months. Many of the other drugs directed against EGFR exon 20 insertions that Zosha mentioned earlier are also exploring cohorts in HER2. But HER2 really kind of threw us for a loop because earlier, in addition to just the tyrosine kinase inhibitors that we're used to looking for, potentially some activity against antibodies directed against the surface expression of HER2, we had some data on an antibody drug conjugate directed against HER2. So now we're using the HER2 as an address label to deliver a toxin. And these all have fantastic names. So this is trastuzumab deruxtecan. So I like to say antibody drug conjugates, whether you can pronounce them or not, they're coming for you. Well, this one here has got a 62% response rate in the HER2 mutants. Now that's higher than in the HER2 overexpressing by immunohistochemistry or amplification. And it may be because of 2 reasons. First of all, if you're addicted to that pathway, maybe you can't shed the epitope as a mechanism of resistance. Secondly, maybe you just have higher expression because that's what's really important to the cancer cell. And I said 2 reasons, but there's actually 3. Maybe that mutation also dictates the underlying biology of the cell. And in the same way that pemetrexed is hyperactive in those with gene fusions, maybe this particular warhead happens to be hyperactive in those who have a HER2 mutation. But a 62% response rate is not to be sneezed at. If you look at the waterfall plot, it really is quite impressive. And of course, people are now starting to look at really interesting other combinations that you can take combining these with tyrosine kinase inhibitors, some very nice data came out of Memorial Sloan Kettering with an irreversible HER2 inhibitor, actually increased the efficacy in breast cancer. So maybe there's going to be a role for both in this subtype of lung cancer.
And we've covered a lot of the things we consider when we're formulating a treatment plan and a practice pattern. This has been great input. We do have to adapt based on an individual patient's circumstances. And I think one thing we've seen over the past year is adapting these same paradigms into early stage non-small cell lung cancer. While unfortunately, the majority of patients still present with advanced stage disease, an important subset have early stage, potentially resectable non-small cell lung cancer. And at ASCO 2020, we saw the results from the phase 3 ADORA trial, which really opened up a new paradigm. Zosha, can you refresh our memory?
Absolutely. So ADORA was, I think, a really exciting trial that I hope will really, open the doors for many other similar trials in the future. ADORA looked at adjuvant osimertinib in patients with resected, the overall population here was stage 1B to 3A EGFR mutant lung cancers. Now, if we think back prior to ADORA, we'd had a number of studies looking at first and second generation EGFR inhibitors in lung cancer. For historical reasons, some of those studies were actually done in unselected populations, and I think the data in the selected EGFR mutant populations was quite limited. ADORA was one of the larger studies and more recent studies to be done. And in ADORA, the primary endpoint was disease-free survival. So these patients had resected stage 1B to 3A cancers, I should say. They could have adjuvant chemotherapy per their current standard of care. The primary endpoint was disease-free survival here in this population shown on the left, the stage 2 to 3A patients. The DFS in the stage 1B to 3A patients was not the primary endpoint of the study, including the 1Bs there. But if we look at the stage 2 to 3A patients, you can see here the DFS hazard ratio was 0.17, 83% reduction in the risk of recurrence or death. If we look in the overall population, including the stage 1Bs, also positive, I think equally impressive hazard ratio here of 0.2. When we looked across the stages of cancer, we could see that the patients with the higher stage cancer, stage 3 patients, had the greatest magnitude of benefit, but we did see benefit across the board in terms of DFS. Now, there was a lot of debate in the lung cancer community after ADORA came out. OS is, of course, a key secondary endpoint, but that data is quite immature, and we really, it'll be years before we have that information. So right now we have to make decisions based on DFS. And we did see that based on this data, the FDA did approve adjuvant osimertinib, and I think it has become a standard of care for our patients with resected EGFR mutant cancers. So of course, it'll be really important to await the overall survival data, but for now, I think this is something that we have to consider in clinic for our patients with resected disease. And I think, testing for EGFR is now incredibly important in patients with resected cancers. There are also other studies ongoing in the early stage setting, and this is the Alchemist trial that's being run through a cooperative group network. And this is looking both at resected EGFR mutant and ALK positive patients. Now here we're looking at adjuvant erlotinib versus placebo for 2 years in the EGFR mutant population, and 2 years of crizotinib versus placebo in the ALK positive population. And these studies are ongoing. I think it's always a challenge when we know that the field has moved forward, and these drugs may not necessarily be our current standard of care for these patients in the metastatic setting, but nevertheless, these data will, provide more information about how we should think about adjuvant therapy, not just in EGFR, but also in ALK. And then we also have other really interesting studies, including NeoADORA, which are looking at patients with resectable stage 2 to 3B EGFR mutant lung cancers and looking at the role of neoadjuvant therapy. So here patients will actually be randomized prior to surgery to one of 3 treatment arms, either placebo plus 3 cycles of chemotherapy, osimertinib plus 3 cycles of chemotherapy, or osimertinib alone. And then these patients will go on after their induction therapy to surgery. Here, the endpoints will include major pathologic response and path-CR rates. And then they will have the adjuvant investigator's choice, so whatever is considered optimal therapy for those patients, including both chemotherapy and TKIs. And endpoints will include both disease-free and overall survival. So I think this will be one of the first studies to look at neoadjuvant osimertinib, and really an interesting study design here. And then finally, we have LCMC4, which will be looking at a number of different targets.
Now, Ross, your thoughts on targeted therapy in the perioperative setting?
Well, it's interesting because with all of these early stage trials, we're trying to take a surrogate endpoint. So in the adjuvant setting, it's disease-free survival. In the neoadjuvant setting, it's often major pathological or complete response rate, and then assume that that's going to translate into some meaningful benefit later. One of the issues is that going to be the same when we're talking about chemotherapy, when we're talking about immunotherapy, or whether we're talking about targeted therapy? I think certainly that has to be proven. One of the things I'm slightly worried about in the neoadjuvant setting is you can get such fantastic responses that at the time when the surgeon actually resects, they may actually understage the cancer, and there may be a lower amount of lymph node spread than actually is there, but truly suppressed by the TKI. And since the trials include this element which says, investigators' choice of adjuvant therapy, I'm a little hesitant about whether we're going to be sort of lulled into a false sense of security, but only time will tell.
Now, this has been a great time. We are running up against the clock, but I think we have a few questions from the audience that I'd love to address. This first one's a good one. Alex, what techniques or approaches do you recommend for biopsies to get the most out of those specimens?
So I'll bring it back. The old adage, tissue is the issue. And I think that it's important to say it over and over again, regardless of what modality you're choosing. Talk to the person that's acquiring the tumor sample, be it the pulmonologist, interventional radiologist, surgeon, and make sure that you have enough to do all of the biomarker testing, molecular profiling that you need. And so, on a practical level, if you're doing a needle biopsy, stay away from an FNA, do a core biopsy, and if it's safe and feasible, try to get a few passes. But that's really the crux of things. Try to make sure that you have enough tissue to do the testing that you want to do, given the number of actionable drivers that we talked about today.
Yeah, and I think also a good relationship with our pathologist. I think gone are the days where we need 20 immunohistochemistry stains, right? Nothing more infuriating than that. Zosha, here's a question. When would you use checkpoint inhibitors in a patient with an EGFR mutant non-small cell lung cancer?
Great question. I think we covered already in this program the fact that unfortunately, checkpoint inhibitors, certainly as monotherapy, have had pretty disappointing results in the setting of EGFR mutant lung cancers. And as monotherapy, I really don't tend to use them a lot. And if I do use them, it's really when I've exhausted all other treatment options and have sometimes a patient that really feels like it's something that they want to try. But it's always a careful discussion about the risk and benefit. There is limited data, I would say, so far for the use of immune checkpoint inhibitors in combination with chemotherapy in the EGFR mutant and ALK mutant population, primarily from the Empower 150 study, which of course looked at the combination of carboplatin, paclitaxel, bevacizumab, and atezolizumab. And there we did see benefit in the EGFR population, but the numbers there were small. And I think that's a regimen that can have quite a bit of toxicity. Certainly, I think can be tougher than carboplatin and pemetrexed, which is usually my go-to platinum doublet for these patients. So I think the short answer is I don't use a lot of immunotherapy for these patients. And this is an area where we need a lot more research and better and more effective ways to harness the immune system for these cancers.
Let's go to this next question. Ross, what kind of testing would you do for an early stage non-small cell lung cancer?
Well, there's a number of factors to consider. So some of them are practical. So in the adjuvant setting, turnaround time doesn't really matter because you've got a big chunk of tissue and they're going to be going through recovery from the surgery and maybe adjuvant chemotherapy. But I think one issue there is whether insurance is going to cover a full molecular panel, which of course is what we'd be doing in the advanced disease setting. Sometimes you can get it through because if somebody has a higher stage disease, they're more likely to relapse than be cured. And that hasn't been an issue for me in terms of getting it covered. But in other settings, maybe you're still going to have to do single gene testing. If you're looking in the neoadjuvant setting, then turnaround time actually is important because you may be delaying surgery and you want to do it. Again, the idea that a broader panel with rapid turnaround time would be good because more people are going to have something that maybe you can act on. But that's really an approach for tomorrow rather than today.
And as we see more perioperative immunotherapy, like Checkmate 816 and Power 010, becomes maybe even more relevant to know those mutations early on.
Yeah.
This has been a lot of fun. I really want to thank our panel here for their outstanding input. We'll wrap up here, and I'll just mention that driver positive non-small cell lung cancer is much more than just algorithms. It is acknowledging that these cancers are biologically distinct, that they behave differently, and we now often have the ability to treat them differently. We have many agents available, more coming, different modalities, and there are a lot of important subtleties to care that we've touched on today, but none of this happens if we don't find the target. So I think the ultimate message here is to test early and often, to focus on the details, to know what you're looking for, and if you're not sure, to reach out to someone who does this every day. We reach out to colleagues all the time. We get questions from colleagues. I've personally called everyone on this panel for advice at some point, and we're really navigating this space together. That includes along with our patients. And for this activity, we partnered with Longevity, a patient-driven organization. And now we'll turn to a short video from Longevity.
Good evening, everyone. My name is Dr. Upal Basuroy, and I'm the Vice President of Research at Longevity Foundation. Longevity Foundation is a lung cancer patient advocacy group, and we have two main goals. The first goal is to improve outcomes for people diagnosed with lung cancer, and the second goal is improving how people live with lung cancer. And as a part of our second goal, we have a wide range of support and survivorship services. But before we talk about our services, let's talk about how we at the foundation define precision medicine, since that's the topic of today's conversation. Longevity Foundation defines precision medicine as biomarker-driven care, right from pre-diagnosis to diagnosis, treatment, and potential progression. And we have programs and services along the entire spectrum of care for patients and their loved ones. In terms of our support and survivorship services, we have a lung cancer helpline that you can see on the top left. We also have a lot of peer-to-peer support in terms of lifeline support partners or clinical trial ambassadors, and we also have a clinical trial finder. We have a wide range of patient education services, including a very comprehensive website that's called Lung Cancer 101. We have videos, we have booklets, and I'll be talking about booklets on the next slide. And we also provide a list of questions that patients or their loved ones can use to have informed discussions with their treating physician. You can download our booklets by visiting the URL that's on the website. And as you can see, we have a very comprehensive list of booklets that cover a wide range of topics related to lung cancer, including screening and early detection, different histologies of lung cancer, different stages of lung cancer, and different treatment options for lung cancer. And last but not least, what you see on the right is a list of brochures and flyers that are associated with the booklets on the left. And with that, I'm going to turn it over to my colleague, Nikki Martin, who's going to talk about services specific to precision medicine.
Thank you very much, Upal. Hi, everyone. My name is Nikki Martin, and I am Longevity's Director of Precision Medicine Initiatives. I'd like to just speak to you very briefly about some of the biomarker testing specific handouts that we have for patients and caregivers that you treat. These are some of the examples. The one piece in the middle is one that I'd like to call your attention to because it is our biomarker testing booklet. So it's a comprehensive booklet, multiple pages. It's small pamphlet size, but has a lot of information that your patients and loved ones may like to read to understand more about the role of biomarker testing and treatment selection. In addition, the pieces surrounding the biomarker testing booklet that are on the sides of the slide are one-pagers. So you can download these one-pagers, you can print them out from your own office and hand them directly to your patients as they come into your office. Likewise, patients can also download them from the website if they have access to a computer at their home. And finally, I'd just like to call attention to the fact that our biomarker testing booklet is available in Spanish and Mandarin also. In addition, most recently in April, Longevity launched together with many partners, including professional societies, the oncogene groups, including the EGFR resistors, and you heard from Ivy just earlier, and several other partners. We just launched a campaign. It's a public awareness campaign called No One Missed. This is a biomarker testing awareness campaign to try and reach people who normally don't have access or don't know about Longevity and other patient advocacy groups to go out and seek information. So you can find out more information about this health literate biomarker testing public awareness campaign by going to www.nooneMiss.org. And there you can find health literate patient education materials on biomarker testing as well.
And with that, I'd like to thank our panel, our esteemed panel, for joining us today and for all the guidance they've offered. Dr. Ross Camage from the University of Colorado.
Thanks for having me.
Dr. Alex Drillin from Memorial Sloan Kettering.
Been a pleasure.
And Dr. Zosha Petrovska from Massachusetts General Hospital.
Thanks, it's been really fun.
Thanks and have a good night.
This activity is jointly provided by Medical Learning Institute, Incorporated and Longevity Foundation. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/EYW860. This activity is supported by independent educational grants from Amgen, AstraZeneca, Bayer Healthcare Pharmaceuticals Incorporated, Janssen, Lilly, and Turning Point Therapeutics Incorporated. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com.